Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. In previous sessions, we focused on the keratinocytes as well as the melanocytes in the epidermis and some of the more common tumors that they make. In this session, we'll be doing a much deeper dive into a much fuller spectrum of histopathologic diagnosis of melanocytic tumors, but it still goes back very frequently to the fundamental principle of being able to identify a melanocyte at the H&E level as opposed to a non-melanocyte, usually a keratinocyte. So let's remember that the melanocytes are typically present as single units along the basal layer of the epidermis. They're characterized by a clearing or retraction artifact around the entire cell, both nucleus and cytoplasm, whereas in contrast, keratinocytes have the desmosomes attaching themselves to one another. And so when they undergo shrinkage, as is typical of formalin fixation, there is a retraction around the nucleus, if anything. So, how many melanocytes can you identify in this image? I would suggest that you pause and identify as many as you can. More specifically, how many melanocytes are circled here? Now, let's take a look. So this one has clearing around the entire cell. So yes, yes, yes. No, that's perinuclear clearing right there. So that's a keratinocyte. And this is maybe a little tricky. It looks like it's kind of flat and lying there. So that's typically the appearance of a Langerhans cell. So I crossed that one out. So I'd say 3 out of 5. Of course, in real life, it's not always that straightforward. And so here's another image that I'll leave for your independent study. But I would submit that this one's a little trickier to distinguish a melanocyte from a keratinocyte. And so, in the minority of instances where one cannot be certain one is looking at a melanocyte at the level of H&E, there are a variety of immunohistochemical stains that can be used to facilitate the confirmation of melanocytic differentiation. This is not a complete list, but I think this is a fairly comprehensive list for the most commonly employed immunostains for melanocytes. Note that one must be aware of what the expected staining pattern is, nuclear, cytoplasmic, or both in the case of S100. And although most of these markers will stain melanocytes, most melanocytic nevi, most melanomas, there is a notable exception here for desmoplastic melanoma for several of these stains. And of course, no stain is 100% sensitive or 100% specific. So the column on the right here lists some of the normal other types of cells, corresponding tumors, and some specific examples of tumors that stain with these so-called melanocytic markers, but are not melanocytic tumors. So, when I was a trainee, way back when, the world of melanocytic tumors seemed to be simpler, or at least we tried to imagine that it was or should be simpler. So, the benign melanocytic neoplasms were largely the melanocytic nevi, or moles, and the malignant counterpart was melanoma, period. However, it appears that there was probably no amount of collective will that could have made that ideal a reality. And so for a small subset of cases that were thought to perhaps just been primarily controversial or associated with a lack of diagnostic confidence, it's been increasingly proven over the last several years that there in fact is an intermediate group of melanocytic tumors, more advanced than a melanocytic nevus, but not quite melanoma. And so this intermediate group of tumors is being increasingly recognized. Melanocytoma is the term that's currently used in the current classification of skin tumors for the World Health Organization, which I'm going to be referring to from time to time during this talk. I think the first time I heard this term was for pigmented epithelioid melanocytoma, but now we have Spitz melanocytoma, which is the current term for atypical Spitz tumor, AST, and then some older acronyms include STUMP, Spitzoid tumor of uncertain malignant potential. We have melanocytic tumors of uncertain malignant potential, and superficial atypical melanocytic proliferations of uncertain significance. And this expanding spectrum and increased granularity in the classification of melanocytic tumors was made possible by advances in our understanding of the pathogenesis of melanoma at the molecular genetic level. Back in 2009, I was asked by Dr. Klaus Bussam of Memorial Sloan Kettering to pinch hit for him for a lecture on melanoma he was scheduled to give at the Maui Derm meeting. This was shortly after he had co-authored this seminal paper in the New England Journal on distinct clinical and genetic subsets in melanoma. And this slide depicts figures from that paper kindly provided to me at the time by the senior author of the paper, Dr. Boris Bastian, a dermatologist and dermatopathologist, and now distinguished professor of cancer research at UC San Francisco. The theme of my talk was Melanoma is not a single disease. And now, over 15 years later, we can say that all of this information has not only been confirmed, but has been expanded upon in ways that have truly revolutionized the field, including going well beyond the day-to-day diagnostics that is the focus of this session. And as perhaps the most common example, we can see here in the upper left-hand corner that melanomas that arise on intermittently sun-exposed skin, typically superficial spreading melanoma, are most commonly associated with BRAF mutations, and that is now facilitating targeted biological therapy for patients with advanced melanoma. And so now here we have a fairly comprehensive current classification for melanocytic tumors as outlined in the WHO classification. So I get that this is a bit overwhelming, even for me sometimes. And so for this session, I'm going to try to focus with varying degrees of depth on the entities highlighted in yellow. But of course, in the spirit of maximizing wisdom, it's good to have a perspective on what is being covered and what isn't. In other words, the importance of wisdom is kind of knowing what you don't know in addition to what you do know. But let's also take a moment to point out some of the aspects of this current classification. It's not like the older classifications that are based on just one parameter like histopathology. We've got a mixture of different things. So we've got both modifiable factors such as the degree of sun exposure. We've also got non-modifiable attributes such as anatomic site. We have a separate category for Spitz tumors, which is now molecularly defined, and other categories defined by the clinical setting, such as tumors arising in blue nevus or congenital nevus, and even a whole separate category for ocular melanocytic tumors, which we're not going to cover at all. But before getting too bogged down in the world of melanocytic neoplasm, let's take a step back and remind ourselves that many, if not most, pigmented lesions are not necessarily melanocytic neoplasms. They might not even be neoplasms at all. Take, for example, the freckle, perhaps the most commonly encountered pigmented lesion that is never biopsied, essentially. In contrast, solar lentigo and pigmented seborrheic keratosis are very frequently biopsied. Sometimes it seems like more than half the pigmented lesions that are submitted to my daily practice are one of these, frequently to rule out melanoma in situ, particularly lentigo maligna on chronically sun-damaged skin. So solar lentigo is worth taking a look at. These are sometimes present on a spectrum with early or macular pigmented seborrheic keratoses, although while SKs don't always have to occur on solar elastotic skin, by definition a solar lentigo does. So one should appreciate solar elastosis in the papillary dermis, and the epidermal changes include slender and elongated hyperpigmented reedy ridges. Although in some cases it seems that age-related or senile atrophy prevails, and so we don't always see the nice classic elongated reedy ridges that look like they've been dipped in chocolate. And expanded differential diagnosis for hyperpigmented macules that are not melanocytic proliferations, that is to say not melanocytic neoplasms, is quite extensive. However, only a minority of these entities tend to be biopsied. So occasionally we will see biopsies of oral or genital lentigos to rule out early melanoma in situ. However, we generally don't see biopsies of café au lait macules or some of these other syndrome-related hyperpigmented macules. They're just listed here for completeness. We certainly do see from time to time nail matrix biopsies to evaluate melanonychia striata, and a potential pitfall is the presence of physiologic pigmentation in darker complected individuals. Rather than a discrete zone of hyperpigmentation, there would be basilar epidermal pigmentation throughout the epidermis in the tissue sections, and typically clinical correlation will easily resolve that. But if you don't have that, or if you don't have a picture or look at the chart, then you may be fooled into thinking that you're dealing with a hyperpigmented lesion. The earliest benign melanocytic tumor, or true neoplasm, is considered to be the simple lentigo, or lentigo simplex. These are small, evenly pigmented macules, so they're rarely biopsied, but clinically they can be indistinguishable from a freckle or solar lentigo, or most likely a small junctional nevus. In contrast to solar lentigo, solar elastosis is not required. It could be present, just coincidentally, but it's not required. But the simple lentigo is characterized by an increase in the number of small single junctional melanocytes, usually mostly along the bases and sides of slender elongated reedy ridges. So the profile of the epidermal reedy ridges overlaps with that of a classic solar lentigo, but lentigo simplex, or simple lentigo, being a true neoplasm, is characterized by an increase in the number of single melanocytes. For both nevus and melanoma, we'll sometimes refer to this lentiginous pattern of growth. And so the simple lentigo is the prototype for this lentiginous pattern of growth, defined by an increased number of single melanocytes. In the benign variants, they're usually pretty evenly distributed along the junction and mostly within the reedy ridges. The next step in the progression of benign melanocytic proliferations is the lentiginous junctional nevus. And so the simple lentigo, by definition, does not have nests of melanocytes, nests being defined as collections of 3 or more melanocytes along the junction. Now, in reality, we're looking at lesions in 2-dimensional slices. So if you get step sections through what appears to be a simple lentigo, it's not uncommon that you would find tiny nests of melanocytes. Then you can just upgrade it to a lentiginous junctional melanocytic nevus. And here's the summary slide for the 2 different forms of lentigo. So now we've made it back up to the melanocytic nevus. And for melanocytic neoplasms, both benign and malignant, I find it helpful to kind of categorize the different histologic attributes by architecture or growth pattern, and then secondly, the cytologic features of the individual tumor cells. So starting with architecture, this is best assessed at a low magnification, so maybe the 2 to 4x objective. And for lack of a better term, I like to see what can be called an orderly growth pattern. And so we can see single cells if the nevus is exhibiting a lentiginous pattern of growth at the junction, but by definition there should at least be some nests of melanocytes, either along the junction or in the underlying dermis, or both. And when a dermal component is present, we like to see maturation with descent in a nevus. Cytologically, as one would expect, there should not be atypia in a nevus, so no increased or atypical mitoses as well, and typically the host response would be sparse or absent. Examining architectural features in greater detail, the ideal melanocytic nevus is relatively small, symmetric, and circumscribed. Circumscription refers to a sharp lateral or peripheral demarcation to the nevus, especially the junctional component. Ideally, the lesion would end in nests rather than trailing off as single melanocytes. And the nests themselves should be uniform or orderly. There's again that word orderly in every measurable aspect. So uniform size, uniform shape, and uniform spacing of the nests from one another. So the melanocytes are evenly distributed. Even if we have that lentiginous single file growth pattern, the distribution of the melanocytes should be pretty even. And then going it down into the dermis, they can form nests, but also disperse as cords or single file strands. And this is part of a cardinal feature of the dermal component of a nevus, maturation with descent. Sometimes the term zonation is used as well. So the nests of melanocytes and the melanocytes themselves get smaller with descent. They disperse into single file strands, and if it's a pigmented nevus, the pigment tends to be markedly diminished, if not lost completely, at the base of the dermal component. And other degenerative changes are characteristic, neurotization, and the presence of fat cells. There is actually a really wide spectrum in the possible cytologic appearances of melanocytes in a nevus, or melanoma for that matter. But back to nevus, we could call them nevus cells or nevomelanocytes. Perhaps the most common morphology would be round or slightly oval-shaped melanocytes, but they could be spindled. They could be enlarged with enlarged nucleus and abundant cytoplasm, resembling keratinocytes or epithelioid melanocytes. One characteristic nuclear feature is the nuclear pseudo-inclusion, as depicted here. This is commonly seen in intradermal melanocytic nevi, but it's not specific for nevus or melanoma. In the differential diagnosis of nevus versus melanoma, we tend to pay attention to mitoses. Don't really pay that much attention to a single junctional mitosis, however. That probably doesn't mean anything. What we would be more concerned about is if we saw a cluster or hotspot, an increased number of mitoses, or if we had a melanocyte that was above the basal layer that was in mitosis. That could suggest melanoma, but a single junctional melanocyte in mitosis is probably not significant. In contrast, if we see a dermal melanocyte in mitosis, that should prompt searching for additional ones. And in the instances where we do see mitoses in the dermis in a nevus, it should typically be superficial and very low in number. We do not want to see dermal melanocytes in mitosis that are atypical or deep, or certainly not a hot spot. So, which one of these two figures is depicting a nevus? Trainees, pause and select. Remember, the junctional melanocytes tend to have that exaggerated clearing around them. So when we have a coalescence of 3 or more melanocytes forming a nest, that clearing tends to be more exaggerated. In this case, the clefting around the nest is not as prominent as I'd like to see, but notice also that the quality of the cytoplasm is a little bit different. So the melanocyte's cytoplasm contains larger or coarse melanin granules, whereas the adjacent keratinocytes have more of a fine melanin content in their cytoplasm. There's also some scattered melanophages in the upper dermis as well. Here's an additional junctional melanocytic nest. Among the variety of ways that melanocytic nevi can be classified, the anatomic classification is probably the most common. So we have junctional, compound, and dermal or intradermal. We often say IDN for intradermal. So the junctional melanocytic nevus corresponds to a macular or flat lesion in which the melanocytes are confined to the basal layer of the epidermis. With the compound melanocytic nevus, we additionally have melanocytes, usually nests of melanocytes, involving the underlying dermis. And so there's both a junctional and a dermal component forming a compound nevus, although sometimes it seems like 99% of the melanocytes are in the dermis. So the term predominantly intradermal nevus is often used. And then eventually we get to the intradermal or dermal nevus, in which case melanocytes are only in the dermis and we don't have any junctional component. If we take a look at some of the most common forms of melanocytic nevus, we can see that there are some anatomic differences that can be diagnostically helpful. So for example, a lentiginous nevus, it needs to be either junctional or compound because that lentiginous growth pattern is a feature of the junctional component. Congenital nevi can do anything, although a purely junctional congenital nevus is quite rare. Blue nevus must be purely dermal, no junctional component. Spitz can do anything, etc. And in a manner that has been largely corroborated by our understanding of the molecular underpinnings of these different forms of nevi. So how do melanocytic nevi form? Well, we actually don't know, but the prevailing hypothesis for most of the history of dermatology was forwarded in the late 1800s by the great German dermatologist Paul Unna. in which the melanocytes derived from the neural crest first populate the epidermis, the basal layer, and then drop down into the dermis to form a dermal melanocytic component. I couldn't help but think of this as the drop-top theory of nevogenesis. As in a very random but personally fun fact, Paul Uno was born and lived most of his life in Hamburg, Germany. And over a century later, this dropping from the top, if you will, saw great commercial success in the form of the first generation CLK convertible that was manufactured in the city of Bremen, less than 80 miles away. More recently, an alternative theory, Hochsteigerung, has been proposed. This is more of a bottoms-up theory, in which melanocytes originate in the dermis and then ascend up into the epidermis. And this is supported by various observations. For example, true congenital nevi are almost never purely junctional. And blue nevus, which never involves the junction, it's a purely dermal lesion, is molecularly distinct. And the thinking is, and there's evidence to support the presence of a population of dermal melanocytes or melanocytic stem cells, and these can populate the dermis de novo or in response to injury or trauma. Perhaps both theories have some truth to them. Complementing the anatomic classification is a much richer and historically based eponym-based classification that I think was first popularized by the late Bernard Ackermann in his publication on naming acquired melanocytic nevi back in 1992. And I wouldn't necessarily bring this up, except that many or most of these are included in the current WHO classification, those highlighted in yellow. The congenital melanocytic nevus is characterized by a so-called congenital growth pattern microscopically. When there's a junctional component, it typically is lentiginous, as we've reviewed. And congenital nevi, by definition, involve the deep or reticular dermis. Characteristic features include a perivascular and periadnexal growth pattern and dispersion as single-file strands of melanocytes. Now, it's recognized that this congenital growth pattern is also a typical feature in small acquired intradermal melanocytic nevi. And so the true congenital nevus, as defined by clinical presence at birth, is really just a subset, and in routine practice, a very small subset of the melanocytic nevi that we encounter that exhibit the congenital pattern. So clinical correlation and confirmation is required, especially for these small lesions. Now, as we get into medium and large, including giant nevi, those are always congenital. Here is one example of that lentiginous pattern of growth that may be seen along the epidermal junction. It can be seen in a true congenital nevus, as well as simple lentigo, lentiginous nevus, or melanoma. And I would submit that based on this one photomicrograph alone, you couldn't tell what the diagnosis is. This is one example from my old residency days collection where I took Kodachromes of the lesions that I biopsied in clinic, and this is a fairly commonly encountered and commonly biopsied lesion. This is a small acquired intradermal melanocytic nevus, and we can see in the biopsy that it extends into the deeper dermis, where it extends around adnexal structures such as hair follicles, the congenital growth pattern. Not infrequently, in the deepest portion of the dermal component of these nevi, we'll see this benign degenerative change, neurotization, which can resemble a Meissner corpuscle or a neurofibroma. And here we see the deepest portion of this intradermal nevus exhibiting congenital pattern growth with small non-pigmented melanocytes surrounding erector pili muscle and a sweat duct. Giant or bathing trunk congenital nevi pose a substantial risk for melanoma for the affected individual, so these are often removed in staged excisions. And so one typically encounters is a portion of a much larger lesion, and we can see melanocytes filling the dermis going to all edges of the specimen, with single file growth mostly in the deep portions of the congenital nevus. Okay, transport yourself back to the dermatology clinic for a moment. This patient comes in. Would you biopsy this? Well, there's probably not an absolute right or wrong answer here. It might depend on some other clinical considerations. But what I can tell you is that this lesion was not biopsied. It came from the foot of this gentleman standing here with a backpack on his shoulder when he had a bit fuller head of hair than I do now. But the lesion was left alone on the advice of my attendings at the time. At the risk of an improper attribution, I think it was one of our pediatric dermatologist, Dr. Frieden or Dr. Williams. But the comment was they took a look at it, just, out of courtesy, and looked at it and said, no, you better not biopsy that, because if you do, then the pathologists are going to say it's atypical. You're going to have to get it re-excised, and you might be on crutches for a little while. Better just watch it. And for my particular case, that was good, because the lesion actually went away by itself. But this is all just a segue to the topic of acral melanocytic nevus. So this is the prototype of the special site nevus, and so acral nevi can exhibit lentiginous growth, but in addition they can have relatively irregular nesting. They can also even exhibit pagetoid upward scatter. So I think it was Dr. Lebois, also at UCSF, who coined the acronym MANIAC nevus for acral nevus. So it's important to recognize that the threshold and the tolerances for unusual or concerning histologic features in an acral nevus is slightly different from that of other anatomic sites. And one of the clues that can offer reassurance for an acral melanocytic nevus is the presence of the retained melanin in the stratum corneum. So the acral skin of the palm and sole has a more pronounced ridge and furrow pattern. And I think it was probably Dr. Christine Coe from Yale who I heard this from most recently, but the furrows are friendly and the ridges are risky. So what that means is we like to see the retained melanin localized to the furrows and not involving the ridges. Now you have to have tissue that is sectioned perpendicular to the skin ridges in order to really see this. If you in contrast, have the tissue section parallel or obliquely to the ridges, that can actually make it look even scarier. So ideally, you would be able to see the ridge pattern, and we can see that the retained melanin is more or less localized to these furrows. So even if the growth pattern underneath is a little more irregular than you like to see, having that retained pattern of melanin is reassuring. Here is one example of pagetoid upward scatter in an acral melanocytic nevus. And note that the cells are going up in a big group, not only as single cells. And this is not precise, but relative to melanoma, this is somewhat of a characteristic pattern of upward migration in an acral nevus. And the list of special sites for melanocytic nevi seem to kind of go on and on. So here's a more complete list of special sites, the acral skin being the prototype, and the rules for the different sites, they're not all exactly the same. So different rules apply to different extents and different situations beyond the scope of what we can go through now. But I think the first step is to recognize that the sites listed here do have characteristic features, and one does need to consider an adjusted threshold, at least to an extent. Obviously, it's a slippery slope. Blue nevus is unique among the various forms of melanocytic nevus, and this is reflected in the fact that it's associated with activating mutations that are mutually exclusive from those of other acquired or congenital nevi. In fact, some of these genes, GNAC, GNA11, are typical of uveal melanoma. But in the skin, blue nevus is most commonly encountered as a small so-called common or dendritic blue nevus, small blue-gray macule with predilection for the face or the extremities, and characterized histologically by spindled or dendritic, narrow, slender, pigmented melanocytes and associated histiocytes full of melanin, melanophages, usually set within a very collagenous sclerotic or desmoplastic stroma. Less commonly, cellular blue nevus is a larger and deeper lesion composed of fascicles of spindled melanocytes. Here's one example from my old residency days collection where we can see that the blue nevus at scanning magnification shows a focal but not well circumscribed aggregate of heavily pigmented cells that have mostly a spindled contour. At higher magnification, we can appreciate these spindled and dendritic pigmented melanocytes. Some of them have very slender dendritic processes, and we can generally reasonably assume that these in fact are melanocytes, but as a matter of practicality, we never attempt to actually figure out on a cell-to-cell basis what is a melanophage and what is a melanocyte. Sometimes the cells will have more or less distinctive features, but in general, the very slender dendritic cells are most likely melanocytes, and the more enlarged, kind of round ovoid cells are more likely to be melanophages. Another notable and unique aspect about blue nevus is its overall growth pattern. So although we do expect to see that peri-adnexal pattern of growth as we do in other congenital pattern nevi, blue nevi do not exhibit the typical maturation with descent as is seen in other congenital pattern intradermal nevi. Rather, the cells look pretty much the same throughout. So the top of the lesion, the bottom of the lesion, they're all the same small spindled and dendritic pigmented cells and associated melanophages. So we don't expect to see maturation with descent in a blue nevus. Cellular blue nevi are generally larger and deeper tumors. Like the smaller common or dendritic blue nevus, cellular blue nevus is associated with scattered melanophages, but the melanocytes, the spindled melanocytes, are typically a little bit larger, and they typically are not heavily pigmented and form bundles or fascicles of cells extending into the deep dermis or subcutis, again, not exhibiting maturation, but exhibiting that characteristic perivascular and periadnexal pattern of growth. Congenital dermal melanocytosis refers to a group of disorders that exhibit only limited clinical and slightly greater histologic overlap with a common blue nevus, but these are essentially never biopsied. Histologically, one sees sparsely distributed pigmented and spindled dendritic melanocytes, usually not so much in a focal cluster, but more evenly distributed throughout the upper and lower dermis. In this example, we can see an appearance that looks kind of like a common blue nevus, but the lesion is larger and the pigmented cells are distributed a little bit more diffusely and sparsely going to the edges of the biopsy compared to a small common blue nevus. Okay, experienced trainees, pause and diagnose. Is this melanoma arising in a nevus or a combined nevus? Good news, combined nevus. Hopefully this is the area that caught your eye from low power, and as we'll see, this is a characteristic pattern of combined nevus, just a small focal area within a larger kind of conventional congenital pattern nevus, no evidence of melanoma in situ from scanning magnification. A variety of combinations are possible in combined melanocytic nevus, but there are certain characteristic combinations. So intradermal nevus, congenital pattern with blue, Spitz, or deep penetrating nevus are characteristic. And then there's also the BAP1 inactivated nevus that is also regarded as a form of combined nevus. In this particular case, the enlarged, slightly spindled melanocytes associated with prominent melanophages is characteristic of deep penetrating nevus. Deep penetrating nevus is a histologically distinct entity that is regarded as a secondary development on top of usually a conventional small acquired congenital pattern nevus with initial activating BRAF V600E mutation and secondary alterations affecting beta-catenin, resulting in diffuse nuclear immunopositivity in the deep penetrating nevus component. Would you biopsy this lesion based on the clinical and dermoscopic image? Despite the potential bias of recent experience, you would be right to biopsy this lesion, as it was superficially invasive melanoma arising within a small congenital pattern nevus in a young adult. And in contrast to a deep penetrating nevus, we have an asymmetric or off-center collection of melanophages up in the papillary dermis, in contrast to the deeper location of a deep penetrating nevus. How about this one? Experienced trainees, pause and assess. We have melanocytic nests that are somewhat irregular in their size and spacing, but if you notice what's going underneath, We have east-west collagen, we have a scar. So the diagnosis is recurrent or persistent melanocytic nevus, also known as pseudomelanoma. So the scar can create melanoma-like changes, particularly irregular growth. So areas of single-cell predominance, very irregular nesting, even pagetoid upward scatter. One should be cautious about attributing atypia or mitotic activity to the scar, and most importantly, the pseudomelanomatous changes do not extend beyond the zone of scar. Fortunately, in most cases, a residual obvious nevus component is present, and one must ascertain the clinical history, and sometimes it's also necessary to review the prior pathology report and or the prior pathology specimen in order to make a definitive assessment and not overcall melanoma. This is particularly important for spitzoid melanocytic neoplasms. Your diagnosis is halo nevus. Now, when one sees a dense lichenoid host response directed against a melanocytic neoplasm, it is appropriate to consider the possibility of regressing melanoma. But the halo nevus is a small, very circumscribed lesion, generally a compound or dermal intramelanocytic nevus, and in contrast to regressing melanoma, reedy ridges are typically preserved. Sometimes melanomas will have prominent plasma cells in the host response, so we typically do not expect to see prominent plasma cells in halo nevus. We also recognize that a clinical halo is not always present, so if we see all the histologic features of a halo nevus, but clinically there's no halo, the term halo reaction is typically applied. So here we have the dense band-like or lichenoid host response, which is much more prominent than typically associated with any nevus, including a dysplastic nevus. However, also note that reedy ridges are preserved, a feature that favors halo nevus over regressing melanoma. In addition to the preserved reedy ridges, in most cases one can make out some focal residual nevus component, and there's a lack of associated changes of melanoma in situ, as we'll be reviewing shortly. With a complete sampling in halo nevus, one can see the central lichenoid host response flanked by a fairly symmetrical zone at the peripheries where there's a relative loss of the melanocytic component, but persistence of sparse inflammation and preserved reedy ridges corresponding to the halo portion of the lesion, the hypopigmented portion. And in the central portion, the high magnification shows the dense lymphocytic host response, variably obscuring the melanocytic component. Your diagnosis? I think this is a classic, by the way. Dysplastic nevus. One of the more significant, controversial, and challenging topics in dermatopathology. For most of its history, I think the following criteria are fairly standard since the origin of the entity in the late 1970s. So we have major criteria that include a lentiginous or epithelioid proliferation of atypical melanocytes. A key feature is the requirement for cytologic atypia of the melanocytes. These are either junctional or superficial compound melanocytic nevi, so when a junctional component is present, there is a shoulder, meaning that at the periphery of the lesion, the junctional component extends peripherally beyond the central dermal component, with 3 reedy ridges being an approximate rule of thumb. And minor criteria are mostly architectural. They include fusion and bridging of reedy ridges, associated lamellar or concentric fibrosis surrounding the bridged reedy ridges and associated junctional nests, and then inflammatory host response. High magnification of fusion of junctional melanocytic nests between adjacent reedy ridges. Note that the melanocytes exhibit cytologic atypia. One might interpret their nuclei as being hyperchromatic, but in addition, there is some degree of pleomorphism or variability in the shape of the nuclei within the nest, and the overall size of these nuclei is comparable to the size of the nuclei in the overlying keratinocytes, all attributes which constitute atypia in the context of a dysplastic nevus. Here's also the lamellar concentric fibrosis surrounding the affected nests and reedy ridges. I found the diagnostic criteria for dysplastic nevus in the current WHO classification to be noteworthy in several aspects. First of all, it includes clinical features in the diagnosis. So we like to see the lesions fulfilling the clinical criteria for an atypical mole or atypical nevus being at least 5 centimeters in diameter clinically, corresponding to at least 4 millimeters in diameter in a formalin-fixed specimen. In addition, we have our architectural features as well as cytologic atypia with reference to a table that I'll show you in just a minute. Note that the lamellar concentric fibrosis and the host response are not listed. And here is that table with the current guidelines for classifying low-grade and high-grade dysplasia in a dysplastic nevus. My overall sense in following this topic and the literature over the past decade or so is that there's been a relative relaxing or slight downgrading in the grading of the dysplastic nevus. So note that what constitutes mild dysplasia in most previous classification systems is now regarded as not even a dysplastic nevus. Your diagnosis? Please pause and interpret. Spitz nevus, also known appropriately by its descriptive name spindle and epithelioid cell nevus, despite how well characterized it has been clinically, histologically, and even molecularly, has notoriously been one of the most challenging areas in the diagnosis of melanocytic tumors, owing to its high degree of overlap with melanoma. But a classic Spitz nevus typically occurs in a child or young adult, face or extremities, usually as a solitary, non-pigmented papule, although pigmented variants of Spitz nevus certainly do exist. Like melanocytic nevi in general, a Spitz nevus is a relatively small, circumscribed, usually dome-shaped papule composed of spindled and or enlarged epithelioid melanocytes. Characteristic features include the vertical orientation to the spindled junctional melanocytes, as well as vertical orientation to the nests themselves, often with a characteristic exaggerated clefting or retraction around the entire junctional nest. Spitz nevi can be junctional, compound, or dermal. The junctional and compound variants are classically associated with epidermal hyperplasia, with hyperkeratosis and hypergranulosis and acanthosis, and the camino bodies are these characteristic pale eosinophilic globules located at the dermal epidermal junction that represent entrapped basement membrane material typical of Spitz nevus. It seems to me that one of the most classic analogies with Spitz nevus is the appearance of the vertically oriented nests of junctional melanocytes and the vertically oriented spindled melanocytes within them that resemble clusters of hanging bananas. And in fact, if you look closely at some of these banana cluster-like junctional nests in a Spitz nevus, you can see that these nests even have labels on them, just like the bananas. The camino bodies appear as pale eosinophilic globules, usually aligned along the dermal epidermal junction. Semi-extreme close-up. And sometimes they can come in handy when the clusters of bananas are not showing themselves as well as we'd like them to. Notice also the background acanthosis and hypergranulosis. Intradermal Spitz nevi lack the characteristic epidermal hyperplasia and camino bodies, with melanocytes limited to the dermis. And in many cases, it's more of a pure or predominant epithelioid cell proliferation with enlarged melanocytes, often with prominent nucleoli. Pathologists always prefer complete samplings rather than partial samplings, and there's probably no area that's more true for than for melanocytic tumors exhibiting spitzoid features, wherein a symmetrical circumscribed profile with characteristic spindled epithelioid cytologic features in the classic clinical setting can be quite reassuring. And just so you know, there are, truth be told, many histologic variants of Spitz nevus. as well as the recognition and establishment of an intermediate group of Spitz tumors, defined both histologically but more importantly at the molecular level. So there's a variety of distinctive genetic alterations, including HRAS and a variety of kinase fusions that define the spectrum of Spitz tumors, ranging from the benign Spitz nevus to the malignant Spitz melanoma, and an intermediate group, formerly known as atypical Spitz tumor, now designated Spitz melanocytoma. And any one of these points along the benign, intermediate, or malignant spectrum may have alterations in one of these pathways. Significantly, these pathways are mutually exclusive from those found in other common acquired nevi, the majority of which are associated with BRAF V600E mutations. We can see that in the Spitz tumor spectrum, it's a multicolored pie chart, which includes as only a small part of it, not BRAF mutations, but BRAF kinase fusions, along with a variety of other kinase fusions and HRAS. In contrast to a classic Spitz nevus, even an intradermal Spitz nevus, Spitz melanocytoma tends to be a larger and more cellular lesion, extending as a rule into the deep dermis, and can be confirmed at the molecular level or using an immunohistochemical stain that's a surrogate marker for the molecular status, such as ALK. Okay, how about your diagnosis on this one? The extra hint is that if you've been up on the literature, you might recognize these published figures. This clinically benign-looking intradermal melanocytic tumor nodule is the BAP1 inactivated nevus, more fondly known as the BAPoma, or Wiesner nevus, or BAP deficient, or even BAPless nevus, all different terms used to describe this clinically innocuous but histologically often scary-looking intradermal tumor composed of large epithelioid, and therefore spitzoid, melanocytes. Similar to the situation with the deep penetrating nevus, this is regarded as a form of combined nevus with a second hit, this time involving inactivation of the tumor suppressor BAP1 on top of an activating BRAF V600E mutation forming the first part of the nevus. In the BAP1 inactivated nevus, there can be striking atypia, but concomitantly little to no mitotic activity. And a minority of these individuals have many such lesions, signifying the possible association with a tumor predisposition syndrome associated with germline BAP1 mutation, with other characteristic features including uveal melanoma and malignant mesothelioma. Here's one example wherein we can see some markedly enlarged epithelioid melanocytes with large atypical hyperchromatic nuclei, yet no mitotic activity. These cells are amelanotic, but here's a relatively small and here a relatively large nuclear pseudoinclusion supporting melanocytic lineage. And taking a step back, we can see that superimposed on this atypical epithelioid melanocyte component, we have an associated benign or conventional cytologically bland nevus component adjacent. Both components are immunopositive for BRAF V600E, but whereas normal lesional nuclear immunopositivity is preserved in the conventional nevus component, there is a loss of nuclear immunopositivity in the epithelioid component, diagnostic of a BAP1 inactivated tumor. And how about this one? Experienced trainees, pause and interpret. Pigmented spindle cell nevus, or Reed nevus, is classically a small, round, evenly pigmented, but often jet black macule or papule, classically on the proximal extremities of a young adult woman. Widely regarded as a distinct clinical pathologic variant of Spitz nevus, these lesions are uniformly small, very well circumscribed. One can see some irregularity in the junctional nesting pattern, but a characteristic clefting around the nest. as well as mild associated hyperplasia, epidermal hyperplasia. The melanocytes in pigmented spindle cell nevus are relatively limited in their histologic spectrum, so rather than being epithelioid or amelanotic, they're fairly uniformly pigmented and spindled. Melanophages are invariably prominent in the papillary dermis, and we have the typical junctional Spitz features with vertically oriented nests and clefting around the nests. Now, one potential pitfall is the occasional presence of quite florid pagetoid upward scatter of melanocytes in pigmented spindle cell nevus, but as long as the clinical setting and the histopathologic features are otherwise acceptable, we can accept or tolerate quite a bit of pagetoid upward scatter as long as it's confined within the main portion of the lesion and not extending peripherally. So we finally made it past the nevi and some of the low-grade intermediate melanocytomas to melanoma, at least melanoma in situ. But we shouldn't be discouraged because much of the groundwork that we've laid in recognizing the histopathologic features of nevi can be contrasted with those of melanoma. So fundamental architectural and cytologic features in melanoma are often in direct opposition to those characteristic of nevi. Starting with melanoma in situ, we often see asymmetry, and this includes the host response against the lesion. Pagetoid growth is a unique feature of in situ melanoma, which we'll look at in greater depth. And melanoma in situ is often poorly circumscribed in that the lesions are not well demarcated. They tend to trail off irregularly, mostly as single melanocytes. And the nests that form are often markedly irregular in their size, shape, and spacing compared to a nevus. And of course, we expect cytologic atypia, so pleomorphism of nuclei, hyperchromasia of nuclei, increased NC ratios with scant cytoplasm. And here's a second use of pagetoid in the context of melanoma. We have pagetoid growth, which is the upward scatter. We also have pagetoid cytology, so enlarged tumor cells with abundant pale cytoplasm, like those seen in extramammary pagets or squamous cell carcinoma in situ, Bowen's disease. Asymmetry, which includes the host response, can be assessed by drawing an imaginary line through the middle of the lesion and seeing if it looks the same on both sides or different. Poor circumscription is characterized by extension as single rather than nested melanocytes at the junctional periphery, kind of like this. Pagetoid growth or pagetoid upward scatter is characterized by melanocytes present as single or nested clustered units above the basal layer. Melanocytes can typically be identified at the stage of MIS based on cytologic atypia or characteristic cytoplasmic features. In this case, the tumor has abundant pale cytoplasm in addition to the characteristic clearing or retraction artifact associated with melanocytes. I often find myself using the phrase irregular junctional growth kind of as a convenient catch-all for a variety of findings related to the irregularity of the nesting. So it could be irregularity in the size of the nests and or the shape of the nests. They're not all nice round or oval shaped. The irregularity of the spacing of the junctional nests, as well as adnexal epithelial involvement by single and irregularly nested melanocytes. This is in contrast to the congenital pattern growth in nevi, in which melanocytes aggregate around adnexal structures. Here, they're actually present within the adnexal epithelium. Tumor growth also results in increased cellularity, often manifesting as confluent growth along the dermal-epidermal junction. The presence of a thinned epidermis associated with a junctional melanocytic nest has been designated consumption of the epidermis and has been regarded as a potential antecedent to ulceration in melanoma. Cytologic atypia in melanoma follows the usual criteria. In this particular example that shows not only the confluent growth and pagetoid upward scatter, we have pleomorphic variably spindled melanocytes, the largest of which also exhibit nuclear hyperchromasia. I mentioned earlier that I usually don't put much weight on a single melanocyte in mitosis in the intraepidermal component, but nevertheless, atypical, clustered, or suprabasilar mitoses can be significant. In this case here, there is a mitosis in a melanocyte in the superficial spinous layer, so this is one instance where even this single mitosis would support the possibility of melanoma in situ. And so in summary, for melanoma in situ, in the vast majority of cases, we can make the diagnosis at the H&E level without additional special stains on the basis of the presence of usually multiple histologic features in combination, as shown in this example here, and with normal skin as a baseline reference. Invasive melanoma, or simply melanoma, if not otherwise specified, refers to melanoma that has gone beyond the basement membrane of the dermal epidermal junction and invaded the dermis. And most of the appearances here can be described as being in direct opposition to the typical appearances of a nevus. So rather than orderly, we have irregular growth with irregular nests, nodules, even diffuse patterns of growth, a consistent lack of maturation, and often a prominent post-response or even regression. Cytologic atypia is present as a rule, and most examples will show dermal mitotic activity. In this example of invasive melanoma, we can see the absence of dermal maturation. Not only are the nests somewhat irregular in shape and size, but they're not diminishing in size with descent into the dermis. So this nest at the deepest portion of the dermal component is arguably the largest nest in the field. Note also that the melanocytes within the nest are not getting smaller with descent. In addition, we have changes of melanoma in situ in the overlying epidermis. The presence of multiple dermal melanocytes in mitosis suggests the presence of a hotspot. And in contrast to the rare superficial dermal mitosis that might be seen in a nevus, in melanoma, the mitotic figures are often atypical. There has been a general trend in pathology over the last several years towards synoptic rather than narrative reporting of tumors, for which increasing numbers of clinically relevant histologic prognostic parameters have been resulted. And these are required for laboratory accreditation in many cases, such as for melanoma. And so here are listed some of the most essential reporting elements for melanoma: tumor thickness, ulceration, mitotic index, LVI, cytolytosis. The tumor thickness, also known as the Breslow thickness, is measured from the top of the stratum granulosum to the deepest invasive component. Mitotic index is reported on a per square millimeter basis, and the convention is to look for a hotspot. So one scans the entire invasive component and looks for a field that has the highest number of mitoses in a single field, and then you can start counting from there. Ulceration is defined as complete full thickness loss of the epidermal surface and can often be corroborated clinically. Lymphovascular invasion is not always easy to detect by H&E, but it is typically most commonly present in association with thick nodular melanomas. And so the most definitive method for excluding LVI when it's not obvious on H&E is to use one or more immunohistochemical markers, such as the lymphatic marker D240 or vascular lymphatic markers such as CD31 or ERG. Cytolytosis may or may not be evident clinically, but is characterized by the presence of tumor nodules that are separate from the main tumor. And we'll finish this session by reviewing some of the traditional and more uncommon or potentially dastardly variants of melanoma. The first of the four so-called traditional clinical pathologic variants of melanoma would be Lentigo maligna melanoma. This typically occurs in an older population and is characterized by often having a fairly prolonged in situ stage, which we call Lentigo maligna, sometimes persisting for many years or even decades prior to invasion. The presence of severe solar elastosis is required, and this is currently classified as a high cumulative sun damage variant of melanoma. And individual cases have been associated with activating mutations in various proteins such as BRAF V600E, as well as others. UV signature mutations are also commonly associated. In contrast to lentigo malignant melanoma, superficial spreading type melanoma on average affects a younger age group, typically on the trunk and extremities, and on intermittently sun-exposed skin. So this is classified as low CSD, low cumulative sun damage melanoma. And so these typically arise on skin with mild, not severe, solar elastosis, and they exhibit all the classic features of melanoma, typically with very prominent pagetoid growth. And among all the different subsets of melanoma, superficial spreading melanoma is the most highly associated with the activating mutations affecting BRAF V600E. Although nodular melanoma is one of the classic 4 subtypes, it's now been recognized that it can occur as an advanced stage of many different types of melanoma. So lentigo maligna, the high CSD, superficial spreading, low CSD, perhaps most common, but also acral or mucosal melanomas can show the histologic profile of a nodular melanoma, which historically has been defined as a tumor nodule that does not exhibit a significant intraepidermal component. So as a rule of thumb, the in situ component does not extend laterally beyond the invasive nodule. So as an arbitrary but reasonable rule, no more than 3 reedy ridges. Nodular melanomas are much more likely to be associated with ulceration, lymphovascular invasion, and satellotosis. At the upper right edge of this nodular melanoma, one can see invasive melanoma here and relatively minimal extension of the in situ component peripheral to the central tumor nodule. Melanomas on acral skin share some features with lentigo maligna melanoma, as evidenced by the older historical name acral lentiginous melanoma, or ALM. This lentiginous pattern of growth is characteristic. In addition, there often is a prolonged in situ stage, and often years may progress, even decades prior to invasion. Unfortunately, acral melanomas do tend to be detected at a later stage given the greater difficulty in examining acral sites. In contrast to lentigo maligna melanoma, however, acral melanoma, although being the rarest of the 4 subtypes, is equally common in all skin types. There is no relationship with cumulative sun damage. Acral melanoma is characterized by lentiginous, often confluent lentiginous junctional growth. The invasive component is usually overtly atypical, and other features include associated epidermal hyperplasia and a predilection for a desmoplastic invasive component. We'll be looking at desmoplastic melanoma in just a moment. And KIT mutations are the most distinctive mutation associated with acral melanoma, although they're not present in the majority of such tumors. With today's focus on melanoma diagnostics, a discussion of prognostic tests related to melanoma is really beyond the scope of what we can do today, but just for completeness, here is a list of some of the tests that do affect the daily life of the dermatopathologist, if you will. So we have sentinel lymph node biopsies that we review, and we get frequent requests for testing for BRAF V600E mutation analysis, as well as immunohistochemistry for PD-L1, both being related to clinically relevant targeted biological therapy for patients with advanced melanoma. And up and coming include a variety of gene expression profiling assays, which can stratify patients into low or high risk for metastasis at a level of efficacy that, in data to date, appears to be comparable to that which is provided by sentinel lymph node biopsy. Now, for this lesion, with the admitted bias of the context of this lecture, I think that even if you didn't think you would necessarily biopsy this lesion, that you now understand that you definitely would. So yes, indeed, if you didn't suspect already, this is desmoplastic melanoma, which is one of the prototypical melanoma wolves in sheep's clothing, both at the clinical and histologic level. So clinically, these are often amelanotic tumors, not even suspected of being melanocytic. And microscopically, one sees a variety of tricky features. So although we expect to see changes of melanoma in situ overlying an invasive melanoma, with desmoplastic melanoma, sometimes you do get that, but other times it's just kind of a nonspecific lentiginous junctional proliferation, or even no in situ component at all. The tumor cells are also amelanotic microscopically, often bland spindle cells, sometimes mimicking a scar, especially in partial biopsies, particularly notorious. Desmoplastic melanoma clinically occurs on high cumulative sun damage areas, but remember that sometimes the invasive component of acral melanoma can be desmoplastic, and the tumors themselves at the molecular level are also unique, characterized by high mutation burden, UV signature mutations, at least for the head and neck tumors, and uniquely loss of function mutations of NF1 in more than half the cases, typically present in combination with a variety of possible activating mutations involving the MAP kinase pathway. And this work with the NF1 mutations was done in large part by my colleague, Dr. Maya Kiuru, in conjunction with her team at Memorial Sloan Kettering when she was there. And if the lack of overt atypia or mitotic activity wasn't difficult enough, desmoplastic melanoma can also be tricky at the immunohistochemical level as well, being characteristically negative for some of our most specific melanocytic markers, including HMB45, melan A, MITF, and not specific but sensitive PRAME. So PRAME is more often than not negative in desmoplastic melanoma. Fortunately, most tumors are positive for S100, P75, or SOX10. And occasionally a clue to the diagnosis of desmoplastic melanoma will be the presence of an unusually prominent host response, more prominent than you would typically see in a nevus, so-called smart bombs. At higher magnification, one sees prominent collagenous or desmoplastic stroma associated with spindled, often bland, mononuclear cells. Probably the main pitfall is failure to even consider the diagnosis, but once hones in on the cells, one can usually find some degree of atypia with some large mononuclear cells, perhaps some occasional mitoses, pleomorphism, and so as long as one gets one of the highly sensitive immunostains, one normally is well on the way to confirming the correct diagnosis. Depicted here is a fortunately uncommon but unfortunately somewhat classic pitfall with desmoplastic melanoma initially misdiagnosed in the initial biopsy as a scar, and one can see the bland cytology here, and then 9 months later increased cellularity and some overt atypia, but by this time the tumor was a few millimeters thick. And so a basic rule of thumb to avoid getting into trouble with desmoplastic melanoma is simply to consider desmoplastic melanoma for any spindle cell lesion on solar elastotic skin, and by extension probably any spindle cell lesion on acral skin as well. How about this one? Experienced trainees, pause and interpret. Here's high magnification of the base of this lesion, and we can see that these cells are relatively small and have scant cytoplasm. One might wonder if they could be lymphocytes. Nevoid melanoma may well be regarded as the evil twin wolf in sheep's clothing for melanoma pitfalls, being any melanoma that, for one or usually multiple factors, resembles a melanocytic nevus. But the small cell cytology with scant lymphocyte cytoplasm is one of the characteristic appearances, and by profile these typically are nodules, even polypoid papules or nodules with a profile that at first glance resembles an intradermal congenital pattern acquired nevus, but when one looks closely one can see that there's usually something funny about the growth pattern. The nests are not arranged in the typical fashion of an intradermal nevus. There may be a lack of maturation. There may be smart bombs in the form of a unusually prominent lymphocytic host response. And at higher magnification, in most cases, one will get evidence of atypia in terms of mitoses, cytologic atypia, or perhaps this small cell cytology with scant cytoplasm. Note also in this case, then one can perhaps slightly hallucinate a limited amount of maturation with descent of the invasive component. In the context of nevoid melanoma, this has been referred to as pseudo-maturation or paradoxical maturation. Note also the lack of an overt in situ component in the overlying epidermis, which moreover is hyperplastic and crusted, suggesting external trauma. So in this case, it's a little bit of a slippery slope, like the special site nevi. How much can you attribute to site-related or external trauma that might be obscuring the true nature of the melanoma? And finally, we have melanoma exhibiting Spitz nevus-like features, or spitzoid melanoma. In this example, we can see a fairly symmetric and well-circumscribed tumor. It's got a nice flat bottom, high domed profile with epidermal hyperplasia, as would be typical of a Spitz nevus. This is from a child, but one can see in the central portion a disproportionately large nest here, a violation of the normal maturation that should apply to Spitz nevus. And further scrutiny of this disproportionately large and deep nest, we can see overt cytologic atypia and mitotic activity indicative of melanoma. Which brings us back to the modern definitions and classification of what we call Spitz lineage tumors, which are defined at the molecular level by the presence of characteristic kinase fusions and other mutations that correspond with different portions of the histologic spectrum of Spitz tumors, not only Spitz nevus, but also the Spitz melanocytoma and Spitz melanoma, as delineated by Dr. Yi-Wei Ye from UCSF and colleagues such as Boris Bastian and others here and abroad who have largely established the current classification of the Spitz tumors as we know it. And so only a subset of histologically spitzoid tumors are Spitz by this classification. And so in this notoriously challenging differential diagnosis of Spitz nevus versus spitzoid melanoma, probably the single simplest and most useful clue I can leave you is that be aware of the presence of solar elastosis in anything that looks like a Spitz nevus, because Spitz nevus, recall, occurs in children and young adults, whereas solar elastosis occurs in adults. So one should be quite cautious about making a diagnosis of Spitz nevus in any lesion that has skin with solar elastosis. But having said that, the difficulty is compounded by the fact that Spitz melanoma, which some people have referred to as spitzoid melanoma of childhood in the past, Spitz melanoma, as molecularly defined, has a predilection for children, in which case you don't have the solar elastosis as a clue. And in the last two slides, after having spent an hour teaching you how to diagnose nevus and melanoma based on H&E, and then promptly showing you desmoplastic, nevoid, and spitzoid melanomas, I will list some of the ancillary diagnostic tests that can be done for melanoma. Notice that first off, there is second opinions, either by colleagues within or beyond your institution. And this attests to the fact that histopathology by experts remains the diagnostic gold standard, and any other tests are ancillary to that histopathologic interpretation. But we have immunohistochemistry, which I'm going to summarize on the next slide, and then other tests that are increasingly more specialized and perhaps more difficult to get and typically more costly. So we have FISH, copy number alteration, gene expression profiling, and point mutation, specifically TERT promoter mutation analysis has been shown to be helpful in certain cases, as well as multi-gene cancer panels that are typically not so much for diagnosis, but for looking for therapeutic targets. In this last slide, I've summarized some immunostains that can be used to assist in the distinction between nevus and melanoma. The first two are Ki67 and PHH3. These both are completely non-lineage specific markers of cell cycle activity or cell proliferation. These are often combined, being nuclear markers, with a melanocytic cytoplasmic marker such as melan A into a double stain to identify proliferating tumor cells. Other stains include HNB45 and S100A6 specifically, as summarized here, but I find that the only two stains that I've been using with any regularity lately are P16, which is the immunostain as a surrogate marker for one of the FISH probes, 9P21, that is the locus of CDKN2A, and also PRAME, which to me is the most exciting, but it's also definitely kind of the new kid on the block, as I always say. And one here is looking for diffuse nuclear positivity in the lesional melanocytes in melanoma, whereas nevi are typically negative.